When we talk about the difference between necrosis and apoptosis, there are some general themes that I think you should keep in mind when you're sitting for USMLE and COMLEX. Let's talk about some differences. Necrosis is not planned, whereas apoptosis is programmed cell death. Necrosis is always inflammatory, so it's marked by inflammation and swelling of tissue. Apoptosis, however, is not inflammatory. Necrosis is always pathological, no matter what type of necrosis it is. It's always pathological. But apoptosis is only sometimes pathological. So because it's programmed and the body's intending for certain cells to die, that's a good thing. But if that goes out of control and you have some type of mutation, which we'll get into, and develop some type of cancer, which we'll get into, that's when apoptosis can become pathological. But to summarize, necrosis is always pathological, and apoptosis is normally it's a good thing, but when it gets out of control, then it becomes pathological. Some more differences: necrosis is marked by macrophage digestion of the ultimate tissue that gets destroyed, whereas apoptosis, cells die because of a release of a pro-apoptotic factor from the mitochondria. In necrosis, the cell membrane is always destroyed, and in apoptosis, the cell membrane always stays intact, even when the cell shrinks up and dies. So these are some very broad differences, and if there's a theme that you're noticing here, it's that necrosis is noxious, and we're going to remember apoptosis, and I'll get more into that later when I talk about what apoptosis actually is and the different pathophysiologies behind them. But necrosis is noxious, which is to say that necrosis is bad. Look at the themes here. It's not planned. It's marked by inflammation, always pathological. Things are being digested by macrophages, and we're destroying cell membranes. Those are all bad and kind of extreme terms when it comes to killing tissue. But apoptosis, on the other hand, is programmed, so it's intended. It's not inflammatory. It's usually a good thing. Only sometimes is it pathological. It's pretty well controlled in terms of pro-apoptotic factors being released from the mitochondria, and the cell membranes are always intact. So even after the cells die, after you have the death and shrinkage of cells, your cell membrane still is intact. So this is apoptosis, and I'll get more into this mnemonic later, but think about Moses as a religious figure, being a good person who's very purposeful and programming and thinking about what he's doing. That's apoptosis. But necrosis is always noxious. Now I want to talk about apoptosis because it's a very complicated topic. It's got multiple pathways. There's a lot of physiology that you need to know here, and I'm going to simplify all of this for you. So the first thing we're going to do is talk about the intrinsic pathway. There's two pathways in apoptosis. There's the intrinsic pathway and the extrinsic pathway. So let's start with the intrinsic pathway. What you see here is a mitochondria, and depending on which molecule is signaling to the mitochondria, that determines whether or not we proceed through apoptosis and perform programmed cell death. So on the left side of the mitochondria, you see BAX and BAC. These are pro-apoptotic signal molecules, which is to say that when these act on the mitochondria, they promote apoptosis and lead to programmed cell death. On the other side, you see BCL2 and BCL-XL, and these are anti-apoptotic factors, which is to say that if BCL2 or BCL-XL are active, they inhibit the mitochondria and prevent apoptosis. So right off the bat, those are some themes that you need to understand. Now, if we're talking about BAX and BAC, what happens is these signal the mitochondria to release something from pores in the side of the mitochondria, which you see here shown as black circles. And what gets released if BAX and BAC are acting on the mitochondria and BCL2 and BCL-XL are inactive, which means they cannot act on the mitochondria, then you get the release of something called cytochrome C. And when cytochrome C spills out of the mitochondria, it activates something called caspases. And caspases are the end target of apoptosis. When a caspase gets activated, it causes cell death. It kills the cell in a controlled, programmed way. So again, to summarize here, BAX and BAC activate the mitochondria to release cytochrome C through the pores in the side of the mitochondria. Cytochrome C activates caspases, and caspases kill the cell. So this is normal. This is what the body wants because, again, apoptosis is programmed cell death. So if a cell gets injured by something like radiation, if you're out on the beach too long and don't wear sunscreen, you need to kill the cells because if the cell gets damaged, it can grow out of proportion and cause cancer. So this is why, in many situations, programmed cell death is a good thing. And again, apoptosis, we think of apoptosis because it's a good thing. It's a religious figure. It's someone who's very prominent. The other reason that I use apoptosis as our mnemonic here is because backs and back, when they activate the mitochondria, they open those pores, which is to say they part the C, just like Moses did, allowing room for cytochrome C to spill out of the mitochondria, cross the river, and do its job by performing programmed cell death. So that's what happens when backs and back activate apoptosis. But what happens if BCL2 and BCLXL are the ones that are activated? Well, in this case, what happens is you never get the release of the cytochrome C from the side of the mitochondria. And when that happens, you cannot activate cytochrome C, so you cannot activate caspases, so you do not get cell death. And instead of cell death, you get inappropriate amounts of cell survival. So if too many cells are not dying, they're living. And what happens is they grow out of control. So if you have a mutation where BCL2 becomes overactivated, which is to say that it's completely preventing programmed cell death and cells are growing out of control, that's follicular lymphoma. And you may have memorized without even realizing that follicular lymphoma is a translocation between chromosome 14 and 18, which overactivates BCL2 because BCL2 gets overactivated in that translocation. So think about it, guys. If you just brutally memorized that follicular lymphoma causes BCL2 to get translocated and therefore activated, what did that actually mean? Well, BCL2 prevents apoptosis, prevents cytochrome C, prevents caspase activation, prevents cell death, so cells grow out of control and you get cancer. You get follicular lymphoma because cells aren't dying, they are multiplying. So that's the intrinsic pathway of apoptosis. And the high yield summary is shown here. Backs and back cause apoptosis by activating C and then caspases. BCL2 and BCLXL inhibit apoptosis and never let that happen. So the end result here is activation of caspases, which causes apoptosis. That's the intrinsic pathway. Now let's talk about the extrinsic pathway. And when I'm done with the physiology on this side, we'll wrap up with some mnemonics for both of these pathways. So in the intrinsic pathway, you can have binding of one of two molecules or both to activate the extrinsic pathway, and they are shown here. Fas ligand can bind to the Fas receptor, or TNF alpha can bind to the TNF receptor. In either of these situations, whether it's one or both, you get the activation of something called initiator caspases. And these are basically like baby caspases that then go on to activate the big daddy caspase. And again, when the big daddy caspase is activated, it causes cell death. So this is the extrinsic pathway. Now, the tricky thing about the extrinsic pathway and why it's really kind of hard to memorize for USMLE and COMLEX is that there's actually two different ways that the extrinsic pathway can be activated. It can be through the Fas ligand TNF alpha binding, or it can be through the activity of a cytotoxic T cell. So if a cytotoxic T cell comes up and latches onto a membrane, it can release something called granzyme B. And granzyme B literally perforates a membrane and allows the release of something called perforin. So granzyme B breaks through this membrane and perforin enters the cell. And when perforin enters the cell, perforin goes on to activate caspases. And if you're not already seeing this theme, whenever you activate a caspase, it causes cell death, programmed cell death. That is to say, it causes apoptosis. So whether you're in the intrinsic pathway and you use cytochrome C to activate caspases, or you're in the extrinsic pathway and you bind Fas ligand to Fas or TNF alpha to the TNF receptor, where the cytotoxic T cell spits out granzyme B that perforates a membrane that activates perforin, all of these things activate caspases, which cause apoptosis. So if you're with me so far, you already know the physiology of apoptosis. You know how this works. Now let's give you some sexy mnemonics to make this easier. So when we're talking about the intrinsic pathway, our mnemonic is going to start with BCL. Now, the way that we're going to remember that BCL2 inhibits apoptosis, which causes cell death to not happen, is we write out the word BCL, as you see here in red text. And we're going to add some letters to BCL. We're going to make it into the word broccoli. So BCL is still there, we just added some letters. And what does broccoli do? It keeps you alive. You live longer if you eat broccoli. Just like broccoli or BCL, BCL2 will make the cells live longer and it'll keep them alive. It inhibits apoptosis. But what about the extrinsic pathway? Where's the sexy mnemonic for that? Well, Let's talk about that. So in the extrinsic pathway, I need you to remember that cytotoxic T cells release granzyme B, which perforates membranes, activates perforin, which activates caspases. I know that can seem like a lot, so how are you going to remember this? Let's write out some words that represent each step in this mechanism. So toxic for the cytotoxic T cell, granny for the granzyme B, and perf for perforin. So what happens if you're really, really toxic in front of your grandmother? You'll cause her to perf. You'll cause her to get really, really mad, maybe even have a stroke if you're not careful. So don't be toxic to granny and cause her to perf. That's the extrinsic pathway. If you're toxic, you'll make granny perf. Toxic for cytotoxic T cell, granny for granzyme B, and perf for perforin. Again, all of these pathways, intrinsic or both of the different types in extrinsic, they all end with caspases, causing cell death. I really don't think it's that tough to remember, but if you're with me so far, you are a master of apoptosis, and you'll be able to answer any question that they throw at you on USMLE or COMLEX. That's apoptosis. Not as bad as some of the textbooks make it sound, right? Let's move on to necrosis and quickly summarize the different types of necrosis. Now, necrosis is admittedly a lower yield topic than apoptosis, and because of that, I'm going to quickly go through this table that's going to summarize everything you need to know. There are 6 different types of necrosis that are technically fair game for boards: coagulative, liquefactive, caseous, fat necrosis, fibrinoid necrosis, and gangrenous. In each of these, I'm going to give you an example of where you'll see this type of necrosis. I'm going to tell you what you'll see on the histology, and then I'm going to give you my sexy, dirty USMLE mnemonics. Remember this. This is really, really easy and a little lower yield than apoptosis, so we're going to move through this quickly. So for coagulative necrosis, you see this in most types of ischemia. Not all types of ischemia, but like 90% of it. So if it's an ischemic event that you're seeing on your test, and you have to take a guess, pick coagulative. On histology, you'll see eosinophilia. So they'll use an eosin stain, and you'll see a lot of eosinophilia. And the mnemonic here is coagulation, because think about it. If you have a problem with coagulation, then that's where you have ischemia. And ischemia is coagulative necrosis, and coagulative has coag literally in the name. So problems with your coagulation cascade cause ischemia. The example of coagulative necrosis is ischemia. And then you just got to memorize eosinophilia. So I took out, a lot of the difficulty in memorizing here. In liquefactive, you see this in abscesses. So abscesses classically on histology have neutrophilic debris inside of them, and the mnemonic here is liquid factive. So instead of saying liquefactive, say liquid factive, because if you've ever seen an abscess before, the center of it is filled with neutrophilic debris, but it's pus, right? It's liquid. So if you don't know what an abscess looks like, Jesus, Google it, because you're going to see a lot of them in your career. But abscesses are filled with liquid, pus, neutrophilic debris. That's liquid factive, aka liquefactive necrosis. Caseous, you see in tuberculosis and in fungal infections. On histology, you see lymphocytes and macrophages forming granulomas. So the mnemonic here for caseous, instead of saying caseous, I want you to say cheesious, because fungal infections, you might say that they look a little cheesy if you've ever seen them. They have this like cheese-like quality to them. So cheesious reminds me of caseous, and I tie that back into TB and fungi because fungal infections look cheesy sometimes. And then if you know anything about tuberculosis, you already know about the granulomas on histology, so you should know that lymphocytes and macrophages are going to be present. Moving on, fat necrosis. This is in pancreatitis. It's also in trauma to the breast in women. Histology, you'll see saponification and complexing with calcium. And the mnemonic here, there really isn't one. It's just the name, fat. Around the pancreas, you have lots of fat deposition. Around female breasts, you have lots of fat deposition. So breast trauma is fat necrosis, and pancreatitis is fat necrosis. So I just remember the word fat, which reminds me of the organs that classically have a lot of fat. That's fat necrosis. The last two I'm going to group together here because they're the 2 lowest yield on this chart. Fibrinoid necrosis you see in any type of vasculitis. You see fibrin thickening of the vessel. So fibrinoid literally has fibrin in the name, so there's no mnemonic for this one. Gangrenous, you see this in distal extremity ulcers like diabetic foot ulcers. On histology, this is a combination of coagulative necrosis plus liquefactive. So you'll see a little bit of eosinophilia. You'll see a little bit of that neutrophilic debris. And the mnemonic here, also really easy. It's gangrene. So People refer to gangrene like it's a medical process. And technically, when someone says gangrene, what they actually mean to say is gangrenous necrosis. But of course, lay people don't use that term. But if you know what gangrene looks like or can imagine someone having gangrene or gangrenous necrosis on the bottom of their foot, that is the mnemonic for remembering gangrenous necrosis. But again, this chart is a summary, a little bit lower yield. Apoptosis is definitely the big topic in this video, but no coagulative liquefactive caseous and fat. And if you have the memory available, throw in fibrinoid and gangrenous. But that's it, guys. That's apoptosis versus necrosis. High yield summary of everything that you need to know and absolutely nothing more. I really hope that this was helpful.